Sorry. Okay, as we're grabbing our seats, it is my distinct pleasure to introduce Dr. Roy Kessels from Nijmegen. I don't think I butchered it too bad this time. So you heard Roy a little bit earlier talk about some of the work that we did with some strategy training in patients with Korsakoff's, but Roy's going to be talking about a different form. So we're shifting gears a little bit in the session to look at some other techniques. So Roy will tell us about some errorless learning work that he's really helped to pioneer.
Thank you, Ben, and thank you also very much for the invitation to be here. Yeah, so I think I will be talking about those patients with memory impairments that just gone over the tipping point where these internal strategies are no longer effective. So the dementia stage, and I'm also presenting some work in the Korsakoff patient group who share a lot of at least cognitive deficits with the Alzheimer group. And I also don't have any images of the brain, no neuroimaging, no biomarkers, and no disease modification. But I do hope you find the talk interesting. So, as you are all probably know, disorders that are characterized by severe amnesia, like Alzheimer's, dementia, Alzheimer's disease, also Korsakoff syndrome, are characterized by explicit memory disorders. So disorders in the memory system that is subserved by the hippocampal diencephalic memory system. We also know, since the days of HM, that implicit memory, procedural learning, priming, is typically spared in individuals with hippocampal diencephalic amnesia. And these are just some recent meta-analysis that Lisa Lotte Witt did with Dr. Glenn Smith that I was involved in as a co-author as well. And also work by Hayes and colleagues in the Korsakoff group showing that these individuals have intact implicit learning capacity. The big question, of course, is can we use these spared implicit learning and memory functions to overcome or compensate for deficits in explicit memory? For instance, to teach individuals new face name associations, learn them a new vocabulary, or teach them new skills. And this is where errorless learning comes into play. So errorless learning was brought into our field, neuropsychology, by Alan Baddeley, the memory psychologist from the UK, who wrote, actually it was a book chapter in 1992, 30 years ago, where he explained his ideas on errorless learning. And he kind of explains that errors during learning are stored by explicit memory, and in the case of impaired explicit memory, these errors will be implicitly consolidated, resulting in erroneous responses because individuals with explicit memory deficits are no longer able to recall these errors and thus produce the incorrect response. And in addition to this notion of Alan Baddeley, there's also a lot of evidence that patients with amnesia, especially those with other cognitive deficits, executive deficits, also have impaired error monitoring. So they are also not able to detect their own errors, let alone correct them. So this led to the idea that error reduction or even full elimination may result in a better learning outcome. And if you translate this to a everyday task, then it could look something like this. When we start to learn a new task, we start doing that task, we make errors, we monitor these errors, we correct them, we continue the task until we have successfully completed it. And when we later have to perform that task again, we think back of that learning experience and recall the errors and avoid them to come to a correct response. But in individuals with explicit memory problems and executive deficits, there are two levels, sorry, going too quick here, two levels where it goes wrong. the error monitoring and correction, but also the later explicit recall. So this was the theory. So is there empirical evidence? Well, the initial empirical evidence came from animal studies by Terrace in the 1960s. This is where Adam Bedley based his book chapter on. And Terrace, who was I think he was a pupil of Skinner, did one of these classic color discrimination tasks with pigeons. And when analyzing the data, he found out that pigeons that accidentally made less errors during learning had a better memory outcome, better learning outcome. So he coined the term errorless learning. And then Alan Bedley teamed up with Barbara Wilson, who's the rehabilitation neuropsychologist from the UK, and they set up an experiment to see whether this would actually work in memory-impaired individuals. So what they did was use a wordless learning task where they presented word stamps that had to be completed, and there were two task conditions. They compared three groups: young adults, healthy older adults, and the mixed etiology amnesia group that included some Alzheimer's patients, Korsakoff patients. I think there was even encephalitis patients in it. And the two conditions looked like this. So words had to be learned, and they were presented by the experimenter in the following way. In the trial and error condition, it was presented as for example, one 5-letter word starting with QU. Can you please guess the word? The participant had to make some guesses. Is it queen? No, that's incorrect. Is it quick? And then after a number of guesses, I think a maximum of 3, the experimenter gave the correct word. No, the word is quote. In the errorless condition, they also had to learn words presented in a similar way, one 5-letter word starting with QU, but then the correct word was immediately given. The word is quote. So there were two conditions: words that were learned in an errorless way, and words that were learned in a traditional trial and error way. And what they showed was that there was indeed a superiority effect of errorless learning. Words that were learned in an errorless way were better recalled than the words that were in the trial and error condition. And they also showed that this effect was largest for the amnesia group. That in fact, it was the only statistically significant difference. That is huge. And that was in line with Bedley's model. Error prevention or reduction resulted in superior memory outcome, especially in individuals that have memory deficits, explicit memory deficits. And this superiority effect of errorless learning has since been replicated in several studies. So we did some work in dementia with experimental tasks, face name associative learning. There have been studies in MCI with, I think, learning names. Korsakoff syndrome, work from Japan, also in the face name associative domain. Mixed etiology amnesia, similar to the group of Bedley and Wilson, and in TBI or ABI by John Evans. And obviously Linda Clare has done a lot of work in errorless learning in the field of dementia as well. She will be presenting later. So the literature, there's quite some consensus that errorless learning is a promising technique. But there's also more critical reviews that argue, well, it is a promising technique, but is it really helpful, and how exactly does it work? Do we understand the underlying mechanisms? Is it really this kind of implicit memory hypothesis? So the prevention of implicit consolidation of erroneous responses would be the working mechanism, based also on work by the group of Barbara Wilson, in which they did not find the source memory, did not find source memory in amnesia patients in a errorful learning design, which suggests them to conclude that this was indeed an implicit, must have been an implicit mechanism, because there was no residual explicit recall. But other studies did not find any relation with measures of implicit memory, primary measures, for instance, the work of Hanken and colleagues. And it's also not always the case that the effect is larger in more severely impaired, memory-impaired individuals. One of the first studies we did was in dementia patients and compared them to healthy older adults and young adults using a phased name associative learning task. And we did find actually a very small effect in the dementia patients compared to the healthy older adults. And this is studies that we are currently performing with Inge Scheper, PhD student, in which we examined whether there's also a direct relation between the number of errors people make and the learning outcome. Because if you hypothesize that the more errors you make, the worse your memory performance will be, then you of course have to show that, should show that empirically, but these studies have never been done so far. So to examine this, we developed a new visual spatial learning paradigm in which we were able to manipulate the errors, the number of errors that were made during learning. So in the learning, in the trial and error learning condition on the top, individuals had to search for objects that were presented on the bottom of the screen. And the instruction was basically, this is somewhere hidden in this chest of drawers. So it's supposed to be a chest of drawers. You have to click on the drawers and the drawer then opens. If the object is in the correct, is in that drawer, you will see a blue square surrounding that drawer. If it's not in the drawer, then there is a red square indicating that you're in the wrong drawer and you have to search further. And we also explained that these objects were hidden anywhere or in a random way in the chest of drawers. But what the individuals didn't know was that there was no preset location of the objects, because the correct location was predetermined by the number of clicks the individuals made. So the bananas were always found after 2 clicks. So they always made one error, so to say. The flip-flops were immediately found, so there was no error there. The saw was found also after 3 clicks, so 2 errors were made. But the individuals who performed the task did not know, were not aware of that. And we also checked it at the end of the experiment. And this in contrast to the errorless learning condition, where the instruction was, well, you have to remember the location of the objects that are presented. And you have to remember because you have to store them in one of these drawers and remember them later. So there were no errors to be made here. And then later, object location recall was examined, and we computed a kind of distance measure as the outcome measure. So the closer the object was to the original drawer, the better the memory performance. And what we found, so higher scores represent a larger distance, so more errors, so to say, was again that we found in a group of early stage AD patients that errorless learning resulted in, so prevention of errors resulted in a better learning outcome. And this was also found for the controls, and we also found an overall group difference. We did not find an interaction here, but more importantly, what was the main interest of this study was the relation between the number of errors made, so the number of erroneous clicks before the correct location was identified, where we would have hypothesized a kind of linear increase from making 1 error to 2, etc., but we didn't find this at all. So this just to illustrate that the underlying mechanism, the underlying cognitive mechanisms are still not fully understood. There's also very little research on the neural mechanisms. So I said I was not going to talk about neuroimaging, but there's also, because there's hardly any studies that have been done, and certainly no studies that showed clear and consistent effects. So is errorless learning more than just a promising technique, and can we really use it to teach individuals with Alzheimer's, dementia, or amnesia due to Korsakoff syndrome new skills? And for this, we build upon the work of Linda Clare, who performed several case series on teaching individuals with dementia new skills, teach them the names of their social network, or teach them the content of photos from a family album again. And we decided to go for a more systematic approach, a group-based approach, in which we taught individuals with dementia 2 tasks, using to make coffee with the Senseo coffee machine, which was at the time a relatively new coffee machine in the Netherlands, and making a cup of tea with a microwave. And what we did is adopt a strict errorless approach, in which we subdivided this task into a number of steps, used feed-forward queuing, we used modeling, so we made sure that no errors could occur, and if errors did occur, we immediately corrected the individual. And we compared the performance of a group of 80 patients with healthy controls. And what we showed was that the 80 patients had a similar learning curve, acquisition curve as the controls, but their overall performance was at a lower level. And at a follow-up assessment without any training, I think this was after a week, we found in both groups that the performance dropped a little bit, especially in the dementia, actually in both groups. So we also did not find an interaction here. But as you can see here, we did have a control group, but we didn't have a control arm. So we didn't have a non-errorless learning or error-full trial error conditions. So this is what we did in the subsequent study, where we used a within-subject design with a postdoc from France who was in our Alzheimer's Center. And we taught each individual 3 tasks, and we used 3 conditions, and we used a nice counterbalance within-subject design, where we used 2 errorless learning conditions, a strict errorless learning condition, a modeling condition where we just modeled each action, and the trial and error condition in which individuals were only corrected after they made an error. And what we showed was that after 6 sessions, 6 learning sessions, and after a 1- and 3-week follow-up, that these 2 errorless learning conditions resulted in superior performance compared to the trial and error condition. So the strict errorless learning condition used a lot of cues, visual cues, verbal cues, and modeling just used the modeling of the actions and sub-steps. So this was all very promising, and in light of the discussion we had yesterday, so this was kind of proof of concept studies, we performed a randomized controlled trial. And before we did that, we performed a literature study, because errorless learning has been used to teach individuals with dementia skills before, but there had not been a randomized control study. And we also wanted to make sure to look into the most effective ways of delivering this method, so to say. So this is the outcome of that literature study performed by Maartje de Wert, who was doing a PC at the time. We identified 26 studies that focused on everyday tasks, ranging from using a microwave, learning to use the voicemail, using a coffee machine, route learning, etc. With sessions that took 30 to 90 minutes. Most studies used approximately 2 sessions a week, and 10 sessions approximately was the most effective duration. And most studies showed that errorless learning was effective in teaching everyday activities in dementia, and there were only very few studies that had a follow-up assessment after 1 week, sometimes even up to 12 months, showing that the effects were maintained. But the differences in methodological quality were huge, and like I said, there was no randomized controlled study among them. So that's what we did in collaboration with a group of the University of Freiburg from Germany, with a grant from the German Research Foundation. We selected a number of tasks that we would think were relevant for individuals with early stage dementia living at home. So they already had a dementia diagnosis, but they were still living at home getting support. In Germany, we have quite a good occupational therapy system. So it was occupational therapists who could provide some assistance in their home environment. And what we did is divide these tasks then into multiple steps, taught the occupational therapist to train them in an errorless way, where we also used fading. So after successful performance of a task or a series of steps, the number of cues was reduced. We stopped modeling. We used only verbal instructions. When that worked, we stopped the verbal instructions and just prompted. And if errors did occur, we corrected them, but we also started the whole procedure from start to end again and faded. So it was quite a lengthy treatment session, but we really wanted to make sure to adhere to the errorless learning principles. We even made instruction videos for training these occupational therapists who by themselves were obviously already trained to teach individuals skills, but we wanted to make sure that they really adhere to our protocol, and we also measured that. We developed a standardized observation and rating scale. I don't have the time to go into that, but this was a kind of standardized way of comparing tasks that obviously differ in the number of steps and the number of complexity, which we also validated. And performed this multi-center study in Germany in individuals that had to have a diagnosis of Alzheimer's dementia or mixed dementia, living at home, quite a large sample, 168 patients with, we used the MMC at the time still, MMC between 14 and 24. They didn't have any depressive symptoms, and trained by therapists, mostly occupational therapists, but there were also some psychologists between them. And we taught them 2 relevant tasks. And the tasks were selected with the patient, with the informal caregiver, and we also made sure that they could not already perform this task at a high successful level. These were 9 sessions of 1 hour and 1 session a week, in which they trained 2 tasks, so 30 minutes each. And we had 2 treatment arms. The errorless learning treatment arm that was delivered by therapists who were trained in the errorless learning methods, so feed-forward cueing, vanishing cues, a step-by-step approach, but also a trial and error learning condition that we labeled active learning, because we also didn't want the therapist to be biased in a way. So we just explained to the therapist, we have 2 learning methods that may or may not be effective, errorless learning and active learning, and we trained half of the therapists in the errorless method and the other half in the active learning trial and error method, where they also use a step-by-step approach, but encourage guessing and self-correction. We videotaped the performance. We had blind raters after 11, 16, and 26 weeks, and 16 weeks was the primary outcome, and this was also a pre-registered trial. So these were tasks that were trained, light exercises, making a phone call, selecting TV broadcast, tasks like this. And what we found was that the satisfaction rate was very high by all patients in either arm. These patients really appreciated it that somebody came to their home and engaged in some kind of useful or potentially useful activity with them, which is fully understandable, of course, in these early stage AD patients. And then to the results. We were a bit disappointed because both of these training methods, so to say, resulted in a significant improvement on the trained task from baseline to week 16 and to week 26. But there was no time by group interaction and also no main group effect. So it was not that one or the other was more effective, but we did demonstrate that we could teach these individuals useful tasks, and there were huge individual differences, of course. We also had a huge number of secondary outcomes that I will not show in detail: quality of life, measures of everyday activity level, neuropsychiatric symptoms, and we didn't find any effects on that. In those measures. We also looked at potential moderators, and we did not find any, and also the MMC, so the severity of the cognitive decline was not a moderator in our study. So we did find improved performance on daily living tasks in dementia patients, no difference between the two learning conditions, and a study that just came out after our own study also did not find a beneficial effect, but this study had a much larger, much smaller sample and a much larger dropout rate. Actually, our dropout rate was very low. So we performed the first adequately powered RCT on errorless learning, low dropout with blinded ratings, but no difference. So how come? One explanation is that actually both treatment arms were quite structured. So maybe the structuring itself is already sufficient to result in successful mastery of these tasks. And additional error reduction may have not have added value here. There's obviously the neurodegenerative aspect, so may this have obscured long-term effects, especially after week 26, but obviously we didn't find any effects on after week 16 as well. And then the question is the outcome measure sensitive enough? Well, we talked about this yesterday in a symposium, but is the ideal outcome measure? Well, in this study, we wanted to have task performance as the main outcome measure. But even though we validated our task performance rating scale, this may have not been sensitive enough. So how about the other group, the Korsakoff syndrome patients? So Korsakoff patients, they have thiamine depletion-induced diencephalic lesions, mostly in the thalamus, and these usually develop in the context of an alcohol use disorder, not exclusively, but most patients have kind of an alcoholic Korsakoff syndrome. And in the Netherlands, we have a quite an elaborate system that these patients who are no longer able to take care of themselves reside in specialized nursing homes or departments in nursing homes. And since Korsakoff syndrome is not a neurodegenerative disease in the strict sense, these patients may have to live in that sheltered living or nursing home for quite a long time, sometimes even decades. So there's really a need for them to engage in everyday activities, chores that need to be done. But then, of course, they have to be taught. In addition to the amnesia, they also have executive deficits and also additional neuropsychiatric symptoms, lack of apathy, or lack of insight. So can we use errorless learning to improve everyday function in these individuals? So that's what we did next, based on work by the Rotterdam group, who already performed a pilot study in 8 amnesia patients using an errorless condition and 8 other patients in trial and error condition, where they taught them to do the laundry. And they had a number of, I'm going too quick here, a number of sessions over several weeks with follow-up assessments without training after week 9 to 10. And they even had what they call the follow-up spatial condition, where they, because in the errorless learning method, the starting position of the stuff they needed to do the learning was always the same, but they were also wanted to say, well, what happens if we have a kind of modified baseline situation to see whether it's actually transferred to a slightly different situation. And they showed that indeed errorless learning resulted in better mastery of the laundry activity, even after this kind of spatial rearrangement. So we then did a larger study with the network of Korsakoff nursing homes that we have in the Netherlands, where we taught these individuals a number of tasks. They could select a number of tasks, but we also trained the personnel, so the professional caregivers in those institutions, to engage with these patients in an errorless manner as much as possible. So not only when teaching these tasks, but also in everyday life activities, because of the theoretical evidence there is that explaining and relying on explicit functioning is really not helpful in these individuals. So first, the tasks that were trained. So this was just a before and after study. So no control treatment here, but what is shown here was that after training, so the training was done at least once a week, if I recall correctly, and there were 10 sessions, that after these 10 sessions, all these domains of everyday activities, apart from orientation that was not statistically significant, resulted in improved performance. So we didn't have a control group to compare the task performance with, but we did have control institutions who were willing to engage in our study as well, but then kind of dropped out because of logistic reasons, that they said, oh, it's too complicated, we cannot do that now. But they did allow us to do some measurements. So we didn't measure tasks, but we did measure quality of life and neuropsychiatric symptoms in a kind of care of usual setting, and compare them to the institutes that used, adopted errorless learning as their kind of philosophy in their therapeutic milieu. And this resulted in higher quality of life compared to the treatment as usual, care as usual, and also a reduction in neuropsychiatric symptoms on several domains. Interesting enough, not on the apathy domain, which we would have hypothesized, and this was done with the neuropsychiatric inventory, and as you probably all know, it's also not a very sensitive measure. I see I'm running out of time a bit, so I'm going to speed up here. So what we did, based on the research we did in both dementia and Korsakoff patients, that we developed manuals that people could actually use, professional caregivers in these nursing homes. We provided trainings on how best to teach individuals with these severe cognitive deficits new skills, providing examples on how to select tasks, how you could subdivide them into steps, how you could use icons like this that are available on the internet to provide visual cues. And this was actually very successful, because the errorless learning strategy has been adopted widely in the Korsakoff care as best practice. And even errorless learning in dementia is widely used by specialized nursing homes, for example, we have this kind of dementia farms where people engage in everyday activities related to animal care for animals. And they also adopted our errorless learning methods. So maybe this is for the general discussion that we have later. So a lot of questions still open. So what is the ideal outcome measure? Is there any transfer? Well, no, this is a rehearsal-based approach, maybe combined with the kind of external memory aids, because if people have to use external memory aids, they have to first learn to use them, and their errorless learning can be of help. There are other outcome measures called attainment scanning that I don't have time to get into, that may be more helpful, even though they are quite tricky in these cognitively impaired individuals. And then the standardization of task assessments, and one other thing, sensitivity to change of the outcome measures, of course, and meaningful effect sizes and measures that are relevant to the patient and caregivers. So current development that people are working on now, so this is based on a student from the Technical University in Delft, industrial design student who used the errorless learning literature and work we did to come up with a kind of app that could be developed. So this was just a design stage that may help caregivers, informal caregivers, to set up instructions for individuals with dementia for use in their home. And such an app has also already been studied in the Korsakoff field. A recent paper that came out also from the Rotterdam group, where they used an app to set up errorless learning activities, subdividing them into steps, giving cues that people could use. And they're even doing research with smart watches, so that people with memory impairments always have these cues, instructions by hand. So sometimes I get the comment that I'm saying, well, don't we learn from our errors at all? Yes, of course we do. There's also a bunch of literature showing that learning from errors is actually beneficial. But the take-home message I want to give is that if cognitive deficits are too severe, then it does not work anymore to explain and to rely on this correction of errors in everyday life. And if you're interested in the underlying mechanisms, then this is the book I edited with Catherine Haslam from Australia, where we at least advocate that errorless learning is a useful and effective method that can be used across individuals with cognitive impairment, but that the evidence for the efficacy is not always based on the outcomes of randomized controlled trials, sometimes even based on more anecdotal or smaller scale studies, so there's still a lot of work to do. And with that, I would like to thank you for your attention. I don't know whether it's time for one or two questions.
Thank you for that. I have a question about your randomized controlled trial. It looked to me like there was a baseline difference between the two groups.
Yeah.
And so perhaps, and the one group that was the error looked flat to me, and the other one improved. Did you do either an analysis to see if there was an improvement, number one, and number two, to correct for the baseline difference?
Yeah, so we did correct for the baseline differences, and it looks like this, but it didn't result in statistical significant interaction. And there's also, we talked yesterday about trial lists and how rigorous we should be when setting up and analyzing randomized controlled trials. So this was partly done with a group from the school that argue that if you do an RCT, you should never test for baseline differences because you randomized your groups. So I know there's two schools of biostatisticians. One school says never check for baseline differences, and the other, which I'm a psychologist, so I'm from the psychology school, that would be in the line of, if there's the baseline differences, this could be a potential explanation for not finding differences. Yeah. Thank you very much.
Excellent.